Good morning. It's good to see you. I'm Dr. Martin Balaba, and I am from Uganda. This is my very first time in Nepal, and I'm really glad to be here. We are going to have a nice interaction today. I have been following from day one what has been happening, and it's quite interesting. The landscape that is AI in Nepal, what the young people are doing, and I think you need to clap for yourselves, you guys. You're doing really, really amazing. So a hand of applause to you guys. I think the future of this country is really, really bright. And my conversation really touches a very sensitive topic about, how do we leverage artificial intelligence, especially in the global south context. So I want us to have an interaction, right? Are there any medical people in the audience? Anyone working in healthcare? Yes. What field are you working in, sir? All right. Could you just join me briefly here, if you don't mind? I think as everyone else is settling in, please. Yes, just here, please. Who of you has been in the hospital in the last 1 month? For any reason, the last 1 month? Anyone been to the hospital? Okay, 1 year. The last 1 year. Who has been to the hospital? All right. How long did you have to wait in the hospital? Long? Long? All right. What reason did you have? Why did you have to wait so long? Anyone with the mic? Anyone with the mic? Why did you have to wait so long in the hospital? There are no doctors? No doctors? Patient numbers? High patient numbers? Okay. How did they take your records? It was on paper? Interesting. What else? Was there electricity? There was internet? How far did you have to walk? Okay, you're in Kathmandu. Maybe you have many clinics. How about guys in the Himalayas and the remote places? How far do they have to walk? A long distance, right? Level of education of the healthcare practitioners is different, right? You have more concentration of high-level people in Kathmandu and the cities and the rural places, right? Where is AI in all this? Where is AI in all this? Please, feel free. Someone stand up. We haven't yet started. Where's AI in all this? Who sees the opportunity? Yes, please. Okay. Anyone else? Democratize healthcare. How do you democratize healthcare? Interesting. Anyone else? One last one? Automation. Okay. This side, please. Pre-screening. That's like triage, right? To identify case severity, right? Interesting. On this side, where do you see AI in all this chaos? How are you going to build AI when you have paper-based records? Has anyone tried to build an AI for healthcare product in this room or a project? Your experience, sir?
I work in
How did you access the data?
Where the assets available online.
That's online. Did you have any access to longitudinal data?
I mean, a lot of paper-based data is managed via OCR.
Okay. All right. So it's interesting, right? Every time we convene in these technical discussions, we need to ask ourselves, how do we translate all these technical conversations and skill sets into actual impact, right? So from all that we have discussed, we're trying to just frame this discussion, right? To understand that beyond your laboratories where you're developing this code, it is absolutely of no value if it doesn't impact the system, the people, the economy, right? So much as we're doing all these very fancy things that I'm going to talk about in the way that are best thought, right? Because in my understanding, I've been reading the abstracts. They're very beautiful. They're very poetic, right? So code is poetry, right? But until you implement that code, there's no justice. So code is poetry. Implementation is justice, right? Anyone loves hip hop here? Oh, you're a hip hop fan, right? Oh, there's another one. So remember the 1993 movie, Tupac and Lauryn Hill. Poetic what? Poetic justice. So today, we are going to look at AI in a poetic justice framework. So let's get the code that is poetry into implementation that is justice. So for everything in framing this conversation, I would like him to read out a case scenario, and then we'll come back later at the end of our interaction to see if we can actually answer the questions from this scenario. It paints a perfect global south context for healthcare. Please. So just read just here, the scenario, just the scenario up to here. Don't read this.
The first sentence.
Just the scenario up to the question. Yeah, please.
Okay, so the scenario I'm going to present is, imagine you have just published a paper on SOTA, state-of-the-art vision transformer for malaria detection from blood smears. So it has 99.8% F1 score. You fly into a rural district to deploy it, and then you find there is no grid power, only a small unreliable solar panel. There is no connectivity. There is H2G signal at best. There is language barrier. The lab technician doesn't speak English or technical jargon. They speak local dialect. So the question is, how do you turn your code into a life-saving tool in this room?
Was that clear? Yeah? So yesterday, I remember when my colleague was speaking about security, how we focus on the accuracy. Thank you so much, sir. How we focus on the accuracy of these models, without paying attention to what the real implementation scenario is, right? So you have your model, you've tested it, 99%, right? Perfect scores. You take it to rural Nepal, there's no power, right? All right. So thank you so much. Are we ready to go? Perfect. So, have you ever thought of what happens when you hit enter on your code? Right? Of course, within the lab setting, it will work. Within the hospital setting, it might not work. Right? So, over the last couple of days, you have discussed, all the technical things, the beautiful poetry that is code, right? If you don't get that code to work in a real life setting, then there's no justice, right? I earlier on shared about the 1993 movie of Poetic Justice, Tupac and Lauryn Hill, right? So here we've said that code is what?
Poetry.
Code is poetry. Implementation is what? It's justice. So when you combine those two things, in our scenario, like the case scenario we've read here, you right? A model is nothing without a patient or a system. So when you are going to talk about implementation, if you take the scenario of clinics in Uganda or the mountains of Nepal, code is just poetry. But if you successfully implement it, then you've done justice, right? So how do we do that? I would like to ask the gentleman who is working on AI, right? Imagery, right? How have you successfully built an AI product?
We are in the stages of testing it, yeah.
Okay.
In hospitals.
All right. Okay. So oftentimes, I got a question yesterday of how I got to work into tech, right? And I said, tech is not only for developers. Tech is for everyone in the ecosystem that is concerned with creating the impact, right? So for you to appreciate how tech works, especially artificial intelligence, you're going to need clinicians to define the problem. The mistake we often make is we come up with a solution without knowing the context and the core of the problem. You sit in your lab, develop a model thinking it will actually work in the setting, right? But you don't have any doctor, pharmacist, nurse on your team to actually define the reality of the problem. You develop the code and later test it with the doctors. What will happen? The doctors will not take up a solution because actually it lacks depth, right? So you need to work as a team. You need the clinicians to define the problem. You have the data scientists to design and evaluate the models, right? You need the engineers, you the brilliant minds, deploy and maintain the systems. You need social scientists. Why do we need social scientists in technology? Adoption, right? But critically, what does adoption mean? How do you define it from ground zero? So understanding people's social context, right? And nuances, it's really very critical. So you need behavioral scientists, you need social scientists. And this is not working in different segments. It has to be a team, right? One of the successful stories we have in the project I've implemented in Uganda is we have been very deliberate in having social scientists on our teams. Before we even define a problem, I'll give an example. Uganda has, I think, the most beautiful lake in the world, Lake Victoria. It has 83 islands, right? And the people who live in those islands are fisher folk, right? And those fisher folk are very mobile. And because of that, it's very hard to, we've had, since the beginning when there was the HIV pandemic, the mobile population has a higher prevalence of HIV than the rest of the country, right? So what we thought we would do was to implement medical drones to deliver antiretroviral medicine to the mobile population. But before we undertook that project, we did a baseline survey for 2 years just to understand if actually the solution would be relevant. And we used social scientists. We host social scientists on our innovation teams. So we take our time to understand the context of the problem before we innovate. And even going on, in terms of behavior change, adoption of solutions, you always need them. They don't come last, right? So think about that when you're doing your projects and identify these people quite quickly. Then, of course, nothing works if policy is not implemented, right? So that is how you need to think of every time you're in the lab, understand how this should work beyond just the lab, the team you will need. That effectively will make your implementation easier. So don't develop models and test them later on, clinicians. Your rate of adoption will be close to zero. So for you to succeed, have the team, right? Continuous engagement with the end users, prototyping in real clinical scenarios. Please do not develop your models without understanding the problem. What you guys are doing here is technical capacity, right? And learning the different techniques of harnessing data and how to approach the problem and the challenges with the appropriate skill set. And then sustainability. How do you own your project? Yeah? Beyond just funding. You know what's happening in the US? Is USAID still operational in Nepal? So a quick reading about the Nepal healthcare system. It's donor funded, right? And once the donor funds run out, what happens to the systems? Do they close? What happens to your grandparents in the villages or in the rural places when donor funding is cut? They suffer, right? So I think as the Global South, and with the advent of the rapid developments in artificial intelligence, we have a unique opportunity to harness technology to build systems that are sustainable, right? Beyond donor funding, we need to think of sustainable models, yeah, within our healthcare systems as the Global South. So it's very critical. So I'll go back to the gentleman that is piloting the imagery. Sorry, because you're an actual example. Did you follow any of these frameworks when you were developing your model?
1 and 2, yeah, 3, I don't know.
Okay. When I asked if someone has been to the hospital in the last 1 year, who put up their hand? I won't ask him. Who else has been to the hospital for the last 1 year? You've been to the hospital, right? Why would you, imagine you're a doctor and he has developed a model that you're not part of and now he's trying to test it on, in your clinic. Why would you be resentful to the model? Can anyone guess why? It's
The system is unknown to him.
It's unknown to him, so it wasn't participatory. Anyone else? Yes, please. Time. It's increasing his workload, right? Okay. Why else would a doctor in a clinical room having 100 patients to see in a day say, no, I don't want this model? Lack of trust. Okay. How many systems, if any, are used in the Nepal healthcare sector in terms of data, procurement, lab, inventory, and all those things, and they have to be managed by one person? How many? So oftentimes they're segmented, right? And they're often biased towards donors. Not so. Right? So these systems are not interoperable. They're not communicating to each other. And that means the data you capture in one system, you have to re-enter in another system, right? So you're increasing someone's workload, right? So no one is going to take up that system if it's increasing their workload, right? So you have to always be mindful of understanding the infrastructure within the clinical setting before you implement a system. To make it easy, it has to be interoperable. It has to speak to other systems, so there's no double entry of data, right? Making sense? Any questions? Any questions on this side? All right. So we've said for you to successfully implement AI within a clinical setting, it has to be clinically aligned, right? Integrate within the systems. Data stewardship. Most systems are disaggregated, right? And so it's very, very hard for you to access data, right? Longitudinal data to develop really mature models for AI in healthcare, right? So you have to be mindful of what environment. And I'm sure you've learned about federated learning and how you can harness, different pockets of data within our context, right? So you need to be very mindful. Don't go very ambitious to a clinic knowing that there's barely any data, right? How many of you attended our sessions on federated learning? Online, right?
Yeah.
You remember the course that we offered on federated learning? All right. I think there was a gentleman also here. So such techniques give you the reality of data within the global south, right? And then local data ownership, privacy. What's your greatest fear about privacy and AI when it comes to healthcare? And I'll give you a very good example. I won't allow the cybersecurity person to speak. Anyone? Why is it of concern? Misuse? Right? Anyone on this side? This side is so quiet. I'm worried. I want someone from this side. Why is data, privacy, and security very critical in healthcare AI? Anyone? Identity, right? So oftentimes we give the excuse that medical data will always be anonymized, right? Do you really think anonymization is a solution to data privacy? Why? So it can be de-anonymized, all right? I need someone from this side. We shall not continue until someone from this side speaks. Anyone this side? Do you know the techniques of how to manage data privacy in AI for healthcare? How did you manage it?
Differential privacy and augmentation.
Noise injection and techniques like that, right? Perfect. Let me ask you, the data that you used for your imagery, was it real patient data? When you use that data, did the patients know that you're using their data?
I believe our collaborators made sure of that. That was not a part of my job.
Would it be a risk to you if it turns out that patient data gets to de-anonymized and you who developed the model are now responsible for that?
Again, the data that we receive is completely anonymized,
Okay.
and our hospital collaborators, it is their job to take care of that.
Okay. You wanted to say something? Federated learning? All right. I saw a hand up. Okay. Lastly, equity and ethics, right? So, gender responsiveness, your models have to be very explainable. You know all the black boxing that comes in most of these models? You can't even explain how we've gotten the result out, right? So you can't even extend the technical capacity to other people because it was designed out of the understanding of other people and you just feed in and then you get a result, right? So for healthcare, if someone cannot understand that cycle of how I got the result out, right? You can't explain it, then really that is not good for the work that you're doing in healthcare AI, right? And you have to be very accountable. You've heard of third parties selling your medical data. How many of us have health apps on our smartwatches? Your smartwatch. Apple Watch. How many of us? How many of us? Apple Watches? About 5. Good. Do you know what happened to your data last night? You don't. Right? Do you know what happened to your data last night? You don't. Right? Did you sign any agreements with Apple before you activated your watch? Okay. Who read the third party clause about selling your data? And who knows what it states? So do you pay attention to the data clauses before you sign them? Do you know how you end up with targeted adverts for other apps? right? So it's very sensitive. Healthcare data is very, very sensitive. So even when you're using these applications, when you're developing these applications, you have to be very, very mindful of people's what? Data privacy. Of course, third parties, they will put on these clauses because you won't read them and they can sell your data and you have no control and you have no commercial benefit to you as the provider of that data, right? In the West, there are now legal frameworks where people should be paid if a third party sells their data. In the global south, I don't know about that yet, right? But you have to be very mindful. Okay, so how do we translate medical AI into health impact? You remember the scenario? If your model needs high-level technical infrastructure, even in Kathmandu, you might not be operational, right? If you need 5G connection for your model and a fancy phone and all these things, right? In medicine, there's what we call death on arrival. You know what death on arrival is? You rush a critical patient into accident and emergency, you check the pulse and the vitals, patient is dead on arrival, right? Your model will be dead on arrival if you need a 5G connection within our context. Is there 5G in Nepal yet? Do we have 5G in Nepal? The answers are mixed. Do we have? Do we have in this room? We don't have 5G, right? Okay, what happens if it's not in this room or in Kathmandu, but your model needs 5G connection? It's death on arrival. It will not work. So how do you design a model that requires low latency, edge computing? Anyone knows? Okay. All right. Anyone else knows how to design models that can actually work on low connectivity, low latency, edge computing? Anyone? Yes? I can't hear you. Who has a mic? This is an interaction. Who has a mic, please? Please.
When we train a model, not all of the weights actually need to be, not all of the model weights will be used. So we can actually prune the weights and we can do tricks like model quantization, and we can deploy the model locally as well.
Yep. Brilliant. Thank you so much. Keep the mic. This is an interaction. So, for you to deploy medical AI successfully, right? Like my colleague said yesterday, you need to move away from deeply being interested about performance, evaluation, the numerics of it, right? If I developed a model in Uganda with a 99% score, do you think the same model will work at the same rating in Nepal? Why? Data variation. What else? Why won't a Ugandan model work in the Nepali setting?
Ethnicity.
Ethnicity? I can't hear you well. Mike, please. Infrastructure differences. But critically, there's variation in data, right? Good. So, healthcare by design is very, very complicated. When you add the social aspects of it, it becomes really more complicated. So you need to be very mindful of the complex social, technical systems in different settings, right? And we've seen that happen with donor projects. You get a USAID project with its own system sitting in a clinic in Nepal, and it can't work. It can't even be adopted, right? So you develop it in the West, implement it in the South, dead, right? So again, align with clinical workflows, make sure whatever you are developing can easily be integrated within the clinical workflows, right? Be mindful of data and the infrastructure, the compatibility, like you said. And then always remember the team we talked about. It is always multidisciplinary. So I always say my role here as a medical doctor, but who understands technology, I'm like a transformer, right? I need to understand the technology. I need to bring my experience and the depth of the medical practice, yeah? Consolidate the team, and we develop a product that will actually be viable for the system and the setting, right? This has been a song, right? And we all know the structure constraints within the Global South. We've talked about the infrastructure, data constraints, the complexity that is our social-cultural setups. But like the gentleman presented, if we are going to be very viable with our products in AI, offline. Has anyone seen an offline AI tool? Yeah? Has anyone seen it? You've seen it? Hello? Has anyone interacted with one? What was it? What was the experience? And something like that can work in the rural places, right? Friction, latency, connectivity, and you have to be mindful of our imperfect data, right? How much do you think shall we have to do to transform all our paper-based data into digital data for us to develop these models? So how do we move from model centricity to system centricity? The questions yesterday you were asking, I think even in most of your abstracts, right? We see the scores, right? How do we improve the model? By score. This is within your lab, right? Interested in scores. No one is telling you about implementation and the reality that even if it goes by a factor of 2%, it will still be zero impact, right? So, can we change the question? When you go away from this workshop, can you try to think different, right? Beyond just accuracy and the scores, can the system run on low-end devices, edge computing? Does it reduce or increase people's workload in a clinical setting? And the noisy inputs, how are you designing it to? I think Martin spoke a lot about the inputs that can, stagnate models. Is it explainable to non-technical people? Yesterday, he asked me to run his presentation by me, right? And I think it was a setup, right? I'm a medical doctor, he's speaking cybersecurity, right? I think he was testing how green I am. And I think he achieved it. Because some things he was mentioning, they're like a song. I have no idea, right? Now imagine you explaining these AI technical terms to medical doctors, right? They will have no understanding what you're talking about and they will reject it. So try to be mindful that whatever you're doing technically can be palatable to the people you're intending to impact and work with. Does it produce measurable improvements in care processes and outcomes? Remember, at the beginning I said, you're looking at patient impact, systems, and absolutely it translates to economic impact. Because if you can improve systems, if you can improve people, systems, then at a macro level, you register economic impact. So you have to think that way. And like I said, our opportunity with AI in the global south, is for us to leverage it to improve people, systems, and register, tangible economic improvement. That is the challenge I put to you guys in everything that you do. So, we change the metric of success. Improvement in systems, healthcare system performance, not what? We've changed the question from model accuracy. We're now measuring the improvement in healthcare system performance and not the algorithmic what? Novelty. Right? Be mindful that moving forward, if you don't look at the end, the impact that you want to register, and you are, it's not bad to be numerically biased, right? But you have to also be horizon thinking that at the end, if I score 99%, how do I translate this into impact? Then you marry the two. There you will have a model that will be easy to adopt. Any questions? Yes, please.
How can we make AI systems interoperable to non-technical
None? Non-technical people, right? All right. Any other question? Where's the mic? Any other question? How do we make AI palatable to non-technical people? All right.
Hi. So recently I've seen that many of my colleagues have used ECG and EEC datasets to train their models, and they've achieved remarkable accuracy as well. So as a medical professional, do you think those models would translate, or is it basically chasing algorithmic knowledge?
It's the latter. It's the latter. If you subject that model to a patient, to a new patient, right? Because if you use an existing data set and you don't test it within a clinical environment, right? Then you'll be shocked that even with all the beautiful annotation and modeling, it will not be accurate to a patient within my clinical setting. You do not know, you can't, because one, like I said, if the doctors were not in that room to define the problem or to even tell you that this is how COPD looks, right? And you copy it maybe out of the internet and most of these existing databases without the full knowledge of, because even medicine is a changing landscape, right? Yeah. And models do decay. You know model decay, right? So you are using a model that has all data, and now we have new clinical guidelines that define disease otherwise, right? So I'm going to turn up with testing an image on a model that is already decayed. It's accurate in its decay, but irrelevant to diagnosis.
My other question is, assuming we have a domain expert, let's say we have a medical professional, and we ask him to teach us the nuances of EEG, let's say, and would it be feasible to develop a model that can detect like mental disorders early, or is that basically a glorified classification task?
Come again, I lost you a bit on something in the middle.
I'm basically asking if we can potentially use EEG or other signal data for early detection of diseases.
So you're asking if you can work with doctors,
yeah,
to
detect diseases like
to define and
to detect diseases like Parkinson's, Alzheimer's, and such early, so there can be some sort of an intervention.
yes.
So would that be possible, or is the data simply not adequate for that?
So, one, it's possible, right? Two, you go back to source of the data and the availability of the data for you to design a model that can actually translate into the output that you want, right? If you go back to the team, yeah, you have the data, you have the team together, you can design these models that can help you, give you an impression of the disease that you're targeting, be it Parkinson's disease. So I do not know about the availability of data with that particular disease within Nepal, but in systems where that data is available, it's possible. How do you make non-technical people understand systems output? Do we have a teacher here? Do you have a teacher? Okay, let me ask you, how best do you learn? You wanted to answer her? Oh, there's a gentleman who wants to. Here, please, no. Your hand up. Who has their hand up?
I'll give it a go. You can use very different options, visual, audio, and so it all depends on the audience, I guess, but a combination of both methods is probably the most simpler. Depends on who's receiving the information as well. If they're a beginner, you want to start at that level, but if they're more not background knowledge, then you can gradient the information they receive based on that. So it all depends on who the receiver is.
Yeah.
As simple as possible. I would use that approach. Some type of explainability using AI as well. The user interface is probably the most important element of the applications you're talking about. So you want the specialist in that to get that information across.
Absolutely. You know why it becomes very hard for you technical people to explain to me, like he did yesterday? The issue is, in my understanding, the problem. If you try to explain it from a problem-based approach, it becomes easy, right? If I am the doctor and I'm trying to understand how to manage my triage effectively, and you understand my problem, it makes it easy. It eases your explanation of what your solution would be. When you come up with a solution to an imaginary problem I have, it becomes hard for you to explain it to me. Does that make sense? Did I answer your question?
I'm still confused. How can we make it explainable to non-technical doctors? He understands the process, but when I'm a patient and I want to understand why AI system made that decision.
Can you give a mic, please? I'm struggling a bit.
How can we make patient understand why the AI system gave that decision?
Okay. So if you come to the clinic and have an AI agent or tool that I'm using, it's my responsibility as a practitioner to tell you what I'm using, right? But also explain to you why I'm using it, right? You have to approach it from, you don't have to assume the patient knows. Never make the assumptions that, people know what you're doing. You have the responsibility to be open, tell them, I'm using this system, this is why I'm using this system, right? Would you want me to continue with the system? But also remember, you have to be very mindful that, I don't know what the law states in Nepal, but AI cannot be diagnostic, right? It will give you an impression. AI in healthcare, in the stage that it's in, I know it's moving very rapidly, yeah? It is to assist, right? Each process. If you make a mistake as a doctor, right, and you use an AI tool and you misdiagnose the patient, who took the oath on graduation? Not the AI tool, right? So remember, you have a responsibility. And remember, the reason I didn't want to repeat it is everyone has been saying it. The human in the loop. You remember? When you're developing all these solutions, remember, especially in medicine, the doctor and the patient are part of the conversation, right? Did that make sense? Are you convinced? Yeah, but it takes time, right? Also, for the doctor to understand what he's using depends on how involved he was. If he has a knowledge gap, then it will be very hard for him to also translate that knowledge to the patient. Again, it comes back to having the right team. If you have the social scientists, they know how to break down things between the diverse technical groups, right? Make sense? Any question before you move on? I want to save on time. All right. So what has worked in the Global South? NAMI, I hope you all know NAMI, right? And our organization in Uganda are collaborating on a multi-country ultrasound scan study where we're collecting different images in selected sites within the different countries to develop a model that we can use on low-level ultrasound scans within the Global South. So we have different sites from Nigeria, Pakistan, Nepal, Kenya, and all those countries have dedicated study sites where we get ultrasound scans from pregnant women, right, with targeted outcomes that we're looking at, fetal age, placentation, and other aspects. And we want to train a model that we can prospectively deploy in low resource settings. So the objective is to collect ultrasound data from pregnant women. Now for the case of Uganda, this is the hospital where we are collecting this data. And the rationale, we are developing a machine learning assisted ultrasound scan, that is the MOBAS product, to support the untrained. Remember when I said within the rural settings, you have lower cadres of healthcare professionals, HPCs, HCPs. So you want to empower them, right, to use the tool without needing the complex training. So you're collecting this data to train a model that will correctly allow them to run the scans, give them the right outcomes, fetal age, placentation, and the different features, right? That's the object, that's the rationale for the study. And the end point is to collect the data from in form of ultrasound images and video clips to develop and validate the algorithm for point of care ultrasound. And this is happening here in Nepal. Do we have anyone from NAMI in the room? Anyone from NAMI? Anyone from NAMI? But if you want more details about this study that is happening in Nepal, Uganda, Nigeria, Pakistan, please reach out to the NAMI team, right? So this is where we are. Yeah, these are our study sites. So we go back to the reality of implementing this or undertaking this project. What was our technical approach? So we are developing the machine learning assisted ultrasound algorithm to support the task shifting. So if I can support a lower health cadre with a high level tool, means they can get to do more, yeah, beyond just what their definition is. So you won't need a high level professional to do the scan, so they can pay attention to other critical needs within the hospital, right? Make sense? That's what task shifting is. And so the other thing that we're doing is deep learning models that are trained using these images and video clips. And the primary focus, like I said, gestational age estimation and key fetal measures, right? So I want to bother you with the data of, the challenges within the maternal and sexual reproductive health within Nepal, Uganda, and the different countries that are hosting the study. So what was our deployment strategy? Data collection is deep. So what we did to make it very easy, we actually you won't even know that the study is taking place because we embedded it within the routine work of healthcare professionals. So you're not adding an extra study into people's workflows. So the reason why we are successful or we actually got the project running is we are not burdening the staff. It's embedded within their workflows. And we develop different tools that are interoperable, that are deployed locally. So they're sitting locally at the sites, so they don't need your 5G connection and your internet. They're able to scan, capture, they do metadata entry, and they upload that data centrally. And then we are conducting we have a pilot phase of about 18. At that point, the data was collected to validate the feasibility before scaling the project. So in Uganda, we have only one site. So we don't have this ambition of just going, because the more you go out before you control for one site, if the outcomes are really nasty, you know what that means? Imagine if you have a wrong model running in 10 hospitals, high volume hospitals. That's disastrous. And the data protection people will come and arrest you. The security people will come and arrest you. So you don't want to lose your jobs. Implementation insights from this project. So again, it's data generation, not model design, is the primary constraint, right? Access to data. And because these issues exist, there are also opportunities. That's how federated learning came in, right? To understand that yes, these constraints are not failures. How do you harness your challenges, right? And training AI on data collected under real clinical pressure improves resilience and avoids overfitting to idealized environments. Remember what I said? You're developing a model on existing data, right? Assuming that it's going to give a good output. But maybe the data already decayed, the model decayed, right? You're collecting live data, right? So it improves your model accuracies, right? Any question at this point? Right. Yes, sir. Where's the mic?
I don't need the mic. So my question to you is about are there any embedded security features in your data collection to protect some of us who are concerned about how I could manipulate the information that you're collecting? Any form of filtering that is applied? Is it automated filtering, or do you have people specifically writing rules that create that layer of security over the data as well?
Yeah. So the technical team that is doing that is actually sits at NAMI, and they write those rules to make sure that all sites, all the different 5 sites, have those features within the data collection. So you won't have the chance to arrest me. Any other questions? So this is an interesting project that we're undertaking in Uganda, right? In my introduction, they said I am coordinating the AI Hub for Maternal and Sexual Reproductive Health, HASH. So what HASH does, HASH has been supporting different sub-grantees within Africa to develop responsible AI products, both for Anglophone and Francophone countries. Francophone meaning French-speaking, Anglophone meaning English-speaking, right? So in phase 1, we had about 10 sub-grantees, and they came up with different products, predictive models, chatbots, conversational agents, to MVP level. Phase 2, we analyze the viability of those solutions to what can be scaled, right? However, we said we proposed to do it differently this time. We said, okay, there are so many commonalities within our sub-grantees, right? How about we come together and develop one product, right? But that product should be able to work in your respective countries. So the 5 sub-grantees we have for phase 2, we came together to do what we call a co-creation of a multinational conversational agent for MSRH, maternal and sexual reproductive health. What does that give us? It gives us access to variable data sets, right? Because initially each country was doing its own project. But you bring all the data together, you develop a conversational agent that is rigorously developed, right? And now it can work in different countries, right? There are perspectives that the Ugandan dataset brings, that the Kenyan dataset is bringing, the Ghanaian dataset is bringing, and other datasets, right? And then you jointly develop this model, right? That agent now can be deployed in other countries, and it will work on the context of those countries. Make sense? Yeah? So, what was the problem that we were facing? There's limited access to maternal and sexual reproductive health data. I don't know how it is in Nepal. How do you guys get access to maternal and sexual reproductive health? It's very hard? The guys? How do you get access to sexual reproductive health care?
I don't work in Nepal. I
Okay, from India, is it easy?
I mean, yes, we have hospitals and we have a government hospital which is in the labs collaboration.
Okay. Anyone else? Are we imagining that it's very hard? Is there stigma related to accessing sexual reproductive health information? Is there stigma? Is there stigma?
Again, I have not faced that. I am not sure.
Has anyone faced any stigma accessing sexual reproductive health information? Why? It's culture, right? Okay. So, with all that in mind, our technical approach was developing natural language process models trained on locally generated Q&A datasets. So this is what we did. I'll speak for Uganda. In different conferences and public gatherings, we set up a tool, right, where people would just go and ask random questions, anonymized, and then doctors in the back end would answer them, right? So over a period of, I think, about 2 years, we were engaging people differently, right? Meaning the questions that were generating the data was organic. It wasn't synthetic data, right? And the responses to that was real time, meaning when you merge that data of question and answer, you get authentic, data. But we also had to go through a validation exercise for all those data sets before we went into modeling. And because now we are working jointly, it will be multilingual. We have 5 countries. And it has slang awareness. I don't know if you have slang in Nepal. You have slang in Nepal, right? So imagine a model that can speak to you using slang, that can respond to your slang prompts, right? That's what we're trying to develop. And the deployment strategy was, we have to make it very palatable. How many of you use SMSs here? Or USSD, *1 something hash? Many here, right? So you'll find that most of those feature phones run on that kind of technology. So in this multinational conversational agent, it will have an SMS feature. Has anyone heard of IVR, interactive voice response? How you call customer care and you go through those prompts? So that agent will have that ability to interact with the client in different languages, right? So if you're designing a product like that, you have to be mindful of the literacy. So if you can talk to the agent in your language, it means, you're bypassing the literacy barrier, right? And so how, in the implementation of this, we are addressing the cultural relevance, yeah, and the trust of the models that we are developing for this agent. And the functions, it will be a decision support. Like I said, most of these are not diagnostic. So you can't say the agent told me to do this, I did, and this is, it won't be answerable. So the value proposition of this agent, and it's the first of its kind, by the way, in Africa, where different countries are coming together, develop one tool that can work across different environments, right? And across jurisdictions. The value proposition is we are making SRH information inclusive, accessible, usable, and adaptive to address the limited access to quality information and increasing misinformation due to social media, the cultural stigma that you spoke about, LLMs, and peer groups. So you see on the right, these are the different universities or the different entities that are putting this tool together. You have University of Embu, University of Ghana, Addis Ababa, then, Uganda. Uganda's not here, but we are part of it. So this will be one agent, and the result is we want to impact 25,000 adults within the next 4 years. And it will have key features. It will be usable for feature phones, offline functionality, and sign language support, right? If you want to be part of this work, please reach out. It's still an ongoing project. We are also deploying AI for diagnostics we are conducting a study in Uganda on diabetes. We have a high prevalence, especially within the youth. We are seeing the numbers are going up of NCDs, that is diabetes, hypertension, and we are using point of care tests to see if we can decentralize access to testing and follow-up of diabetes within Uganda. And the device that we are using is called, it's a Lumira device. So this is a retrospective study in Uganda where we're testing this device in low resource settings. And this device uses a single fingerprint. It gives you the HbA1c. This is a parameter of following up, monitoring diabetes within established populations. Does anyone have, maybe their parents are diabetic and they run these tests? Usually they are centralized tests, but with this machine, it's decentralized. You can have it within your home or within, but this is within clinics, and want to see if the output is accurate compared to the lab reference. So we have the device and then the lab reference. Want to compare the accuracy of the two and see if we can adopt it to individuals who have within their homes and clinics in the rural settings to have it. And it has AI potential. So predictive analytics, when you have longitudinal data for these patients, what can you do? Machine learning could identify trends and flag patients for early intervention. So if you see that the patients, because of access to the diagnostics, if the HbA1c is, consistently high, you can then intervene to understand, are they adhering to their medicine? Do we need to change the dosage? Then you can also personalize their care. From that intervention, you know exactly how to package their care. And then, because these particular machines are integrated, they have connectivity. So you don't have to get the result and then manually input it within a patient's EMR. I know Nepal has an EMR, right? Not in all hospitals, but I think there's a strategy to implement one open MRS. Not so? That's what I read. Right now, there's no unified electronic medical records in Nepal, but there's a strategy to implement the open MRS across different hospitals, so it can feed into the DHIS too, right? There is no doctor here, so is that right? All right. So these machines the machine has that ability, so you don't have to doubly enter data. And the opportunity is, so when you implement devices like this and adopt devices like this, and integrating them with smart analytics, policymakers, it's easy to scale within the clinical setting and improve systems and patient outcomes, equity and impact in the long run. Integrated AI point of care can democratize diagnostics, advance health equity, and improve chronic disease management across the Global South. There's a company in India, it's called Mobile. The gentleman from India, do you know Mobile? It's a $1 billion company in India that is producing some of the best point of care tests in the Global South. It has been listed on it has done an IPO recently. It sits under big tech. So if it's in Bangalore, you need to check it out if you're into medical tech. It's in Bangalore. They're one of the best manufacturers of point of care tests in the Global South. And they're doing amazing work that also has AI integration. You need to check it out. They're amazing. All right, so how do we move from being consumers? In the Global South, oftentimes we are consumers of products. And for AI, it's possible that we shall be consumers of AI, but we need to move from that mindset to become producers. So we need to do South-to-South collaborations, right? Establish regional AI hubs within Africa, South Asia, like the collaboration between NAMI and our institute in Uganda, Pakistan, Nigeria, right? That's how we harness our potential. And then strategic opportunities lie in sharing data sets, like what we're doing in our studies. Capacity, it will be very nice. Martin was telling me yesterday, because you guys are doing a lot you have a big tech talent in Nepal. How do we tap that tech talent, across the different areas in the global south? And so the goal is contextually grounded, globally competitive medical AI. And this just shows a list of where my organization is working. So we are spread really. We have collaboration across the world. And I hope I was making some sense. There's some takeaways from this before we go back to our exercise, right? Understand the problem before you develop any model, right? Design for infrastructure. Understand that in rural places and other settings, infrastructure, connectivity still stands as a constraint. Integrate it within clinical environments. Understand the policies around it and measure impact using clinical and operational matrices and not your scores, right? Remember at the beginning, right? So understand how your model performs in real settings than in the labs, right? So success will come when the technical rigor meets system reality, right? Equity is embedded by design. Local actors lead implementation. Don't develop in the West, deploy in the South. And the challenge is build AI that solves health system problems, not just computational problems. Right? The boring stuff has ended. Can you go to the most interesting stuff? Any questions?
So thank you, Dr. Martin, for insightful talk. All the products or models that you are designing for your country and entire global south. So my specific question is like, as you correctly pointed out, we have two different systems, the health system and the product development system, which are currently operating in silos. So if there has to be a bilateral communication or flow of ideas or coordination between these two teams, since you have background of both, how would you say like these two systems would communicate with each other?
Come again on the last. I missed that bit.
So to summarize, how do the clinicians or health system people and the product developers communicate with each other so that both of them can be useful for the knowledge sharing and problem sharing so that they come to a unique solution?
Okay. So how do we create synergies between the different teams? Right? How do we create synergies between the different teams so that at the end we have systems communicating, right? Did you mention that there's a government system, there's a private system?
I mean the entire health ecosystem and the product development system.
And the what? I'm missing the last bit.
The product development system. I mean the developers.
Okay. Okay. All right. Makes sense. Noted. Any other question? Are we done? Okay, so usually when you go back to the slide that has a team, I'll give you an example, my experience, right? As a medical doctor who has been overseeing the development, piloting and the scaling of these products, right? When you identify the problem, and of course you understand that you're going to need the engineers, the software developers. So my role then becomes like a product manager, right? And I need to manage the stakeholders. I need to understand the interests and the inputs of everyone on the team to make the project a success. So it becomes my core responsibility to understand the needs, the responsibilities, the inputs of the different teams and create those synergies and manage them to bring this product to life, right? And that's the role of a product manager. So I have had roles shifting depending on the need of the project and the life cycle of the project. But it's very critical to manage the stakeholders in making sure that products come to life. Yeah. Yes, please.
In your experience, which is the best approach? The problem or working with the data and trying to shoehorn the data into the problem?
The problem of?
Well, you can either have data and then try and reverse engineer, try and find the problem that it solves, or do you try and have the problem first and then find the data? Or do you often find that rule-based systems is better than an AI system? Which is your...
Problem first.
Yeah.
Problem first.
And how would you go about finding that problem in your community?
Go to the community. You have to go to the community. Don't do the ivory tower where you sit and assume this is a problem. Go to the community. Talk to the community. Understand the community. Know their problem. Start solving the problem.
Yeah. And if there's no data, then you have to mothball that idea, I guess, or you move on.
The data is always available. You have to look for it. Yeah. Any more questions? Should we? All right. Thank you so much. I'm sure it was quite boring. But if you are interested in the products and the projects that we are undertaking between NAMI, Uganda, and quite a number of other projects that we are undertaking in Health AI, please reach out, right? These products are not developed in silos, right? It is joint collaboration, and we are open to collaboration, right? Thank you so much, and enjoy the rest of